ganglia before we can go to the actual Parkinson disease and then answer the questions. So the basal ganglia is a group of nuclei. We know that this is a misnomer for it to be said the ganglia because it's found in the central nervous system. So some would call it basal nuclei, but commonly called the basal ganglia, found deep in the cerebral hemispheres. It's part of the extrapyramidal motor system, and the principal function is for motor control, meaning that it is controlling the posture and the movements. This is important. We need to know the principal function, but it can also have other functions. So, what are the components of the basal ganglia? We have got the caudate nucleus, the putamen, globus pallidus, subthalamic nucleus, and substantia nigra. So, just to understand them better, so this is the part. This is where it's located. This is the basal ganglia in that region. So, looking at now the parts that make up the basal ganglia, on this diagram, because for the anatomy part we can be asked as well to get to label them. So starting from the top here we can see the lateral ventricles, and then as we are going down we are reaching to a point where we find the third ventricles. And then can you see that on the sides of the third ventricles you have got the thalamus? For the sake of that picture anatomy for laboring, at least we should take note of this. So in third ventricle, and then on the sides we have got the thalamus, and then now the parts of the basal ganglia. We have got these parts here. The first part we have got the globus pallidus, which is more medial, and then as we get to go lateral we are going to have the putamen. Now the globus pallidus has got two parts. There is the internal part and the external part, or the inner part and the outer part. And then we have got the putamen. And then we have got the caudate. Can you see that the caudate is a bit on top there? And then you are also going to have a group of fibers that are going to be able to separate the putamen from another part here that we are calling as the claustrum. You can see the claustrum, and then we are going to have the sylvian fissure, which is at the end, this part of the cortex there, the cerebral cortex. So when you look at these parts, let's talk first about three parts. We have got the globus pallidus. As you go lateral, you are going to have the putamen. And then on top, can we see we have got the caudate nucleus. So now the combination of the globus pallidus, which is medial, with the putamen, which is lateral, is going to form what we call the lentiform nucleus. So those two forms the lentiform nucleus. Please don't forget that the globus pallidus is medial, while the putamen is lateral. The two forms the lentiform nucleus. But the same lateral guy, the putamen, if you combine it with the caudate nucleus on top, that is going to form the corpus, that is going to form the striatum. The striatum. So the striatum is just caudate nucleus and putamen. But then if you combine these three parts, the putamen, the globus pallidus, and the caudate nucleus, that to form now striate corpus striatum. Hope it is fine. We There's a doc that I've posted. They can't see the screen. Are others able to see the screen? Is there anyone who can see the screen just to confirm? Okay, doc. Maybe it's just network. You can just try to disconnect and then connect back. So just an overview. All right. Thank you so much. Just an overview again. What to make up the corpus striatum is the medial globus pallidus, the lateral putamen, and then the caudate nucleus. Now, can you say that from the lentiform nucleus, that is the globus pallidus and the putamen, the lentiform nucleus is separated from the caudate nucleus using this is known as the anterior limb of the internal capsule. So the internal capsule is this structure that is making like a C, having an anterior limb, posterior limb, and the middle part that is known as the genu. So the anterior limb of the internal capsule is separating the lentiform nucleus from the caudate nucleus. The lentiform nucleus being made up of the globus pallidus and the putamen. Globus pallidus has got the internal part and the external part. It's important to understand that anatomy, because as we get to talk about the physiology past the pathways, it will at least requires that we understand a bit about that. So we're actually going to have capsules which are also separating these guys here, but we'll talk about that later on. So the functions of the basal ganglia: planning and regulating stereotyped gross movement. For example, walking, for you to plan and control walking, running, swimming, also maintaining stability of the trunk muscles, modulation of the corticobulbar and corticospinal output systems, which will control the muscle tone, and also emotions like empathy, behavioral drive. So, what is the basic function? How does this basal ganglia do its function? Now, remember, when I want to initiate a function that is voluntary, I want to control a movement. Let's say, for example, I want to move my hand. The information first is coming from the cerebral cortex. And then that information from the cerebral cortex is going to pass through the basal ganglia. The basal ganglia can either say yes or no. So, whatsoever the answer that it says is going to send back the information to the cerebral cortex. And then now a movement is going to be initiated. So, if the information is yes, like the cerebral cortex has said, I need to move. The basal ganglia says yes. That yes is going to be carried in what we call the direct pathway. But if the cerebral cortex says no, that no is going to be carried in what we call the indirect pathway. So that is the basic thing. So when you look at the direct pathway, the cortex is going to release glutamate. So we have got a play of two neurotransmitters here. Glutamate, we know that it is excitatory. So the cortex, cerebral cortex, is going to release glutamate. Glutamate is going to stimulate the striatum. Remember the parts of the striatum? You have got the globus pallidus, and you also have the putamen. So the cortex releases glutamate, which is stimulatory, and this glutamate is going to stimulate the striatum. And the striatum, so the next two parts will be producing GABA. The striatum is going to produce GABA. Now remember, GABA is inhibitory because we have stimulated the striatum to release its neurotransmitter, which is inhibitory in nature. So when GABA is produced, it's going to go to the internal segment of the globus pallidus and also the substantia nigra pars reticularis. These two pars, not pars compacta. So the substantia nigra has got two pars, pars reticularis and pars compacta. So from the striatum, we are going to the internal segment or the inner part or the medial part of the globus pallidus and the pars reticularis. Because it was GABA, so it is inhibiting these two parts. Now, these two parts, the neurotransmitter that they produce is also GABA. So when you inhibit them, what is going to happen is that you are preventing them from producing GABA. So this GABA that they were supposed to produce is low now. You are not producing it because you have inhibited them. So when they are not producing GABA, this GABA, if it was produced, it was supposed to inhibit the thalamus. But then you have not produced the GABA to inhibit the thalamus, so the thalamus is stimulated. So when the thalamus is stimulated, the thalamus produces glutamate, and that glutamate is now going to go again back to the cerebral cortex to stimulate it, and that is how motor movement is going to be stimulated. That is the direct pathway. Please don't forget the neurotransmitter produced on each part. The striatum, which is the globus pallidus, and the putamen, besides them receiving information from the cortex, they can as well receive information from the substantia nigra, but pars compacta, which can produce dopamine via the D1 receptors, and these guys are stimulatory, so they can still stimulate the striatum. The D2 receptors, those are inhibitory. So this is again another diagram just to show what we are from talking about. You're having the motor cortex that is producing glutamate, The glutamate goes to the striatum, which is the caudate plus the putamen. The striatum is going to be stimulated to produce GABA. The GABA is going to the internal globus pallidus and the substantia nigra pars reticulata. And this guy, because we've inhibited these two guys which produce GABA, GABA is not produced. So GABA, because it's not produced, there is no inhibition on the thalamus, and therefore the thalamus gets to produce its glutamate that excites the motor cortex, and then you have got a more muscle movement. Are we fine on this one? Is there any question on this one, or it's good? Okay, so that was the direct pathway. The direct pathway, remember, it leads to movement, but the indirect pathway inhibits movement. So what happens in the indirect pathway is that we introduce one more thing. We are introducing actually not one but two. And those two guys that we are the two guys that we are introducing them just after the striatum. Remember, we have only talked about the internal segment of the globus pallidus or the medial segment. How about the lateral segment or the external segment? So those guys are the ones that are now going to come in. So we're going to bring in the external segment of the globus pallidus, and we're also going to bring in the substantia nigra. I mean the subthalamic nucleus. So of the two that we have introduced, the external segment or the globus pallidus also produces GABA, while the subthalamic nucleus also produces glutamate. So now we have got three parts that produce glutamate. So what is going to be happening is that the cerebral cortex is going to release its excitatory glutamate. That glutamate still stimulates the striatum. The striatum produces GABA. That GABA is going to go to the external segment of the globus pallidus. Because this is an inhibitor, it is going to inhibit the external segment of the globus pallidus. And so this external segment will not be able to release the GABA. So since it can't release GABA, it means that there is a lift of inhibition on the subthalamic nucleus. And so since there is lift of inhibition, the subthalamic nucleus can now produce glutamate. This glutamate is going to now go and stimulate the internal segment of the globus pallidus and the substantia nigra pars reticularis, same as the direct pathway, which are now, because we've stimulated them, they're going to produce GABA. This GABA which you have produced is going to inhibit the thalamus. So since the thalamus has been inhibited, it can't produce glutamate to excite the cortex, and so there is inhibition of movement. And you can see dopaminergic neurons from the substantia nigra pars compacta via D2 receptors can as well stimulate the striatum because the D2 guys are inhibitory in nature. So this is the indirect pathway. I hope it is okay. In case there's a question, let's be free to contribute it. So this is again a diagram that was said that it has to be known for the test that is coming to be brought. Actually, there will be a combination of the direct pathway and the indirect pathway, and then now you just put in the neurotransmitters that are released on each step and which one. So these boxes are going to be given like this. I saw how it was on the paper. So the boxes will be given and then the arrows are shown, but you just put on the neurotransmitters and what will be missing in the boxes. So you can see for the indirect pathway, the motor cortex is going to stimulate the striatum. The striatum, what it does is that it is going to release also its transmitter. That is going to, but remember the striatum releases GABA, and this GABA is going to inhibit the globus pallidus. The striatum, remember we said that it can as well receive information from the D2 receptors via substantia nigra pars compacta. And then the globus pallidus, because we have inhibited it, it is going to, it will not produce the GABA that is supposed to inhibit the subthalamic nucleus. No inhibition on the subthalamic nucleus, so subthalamic nucleus produces glutamate to stimulate the globus pallidus interna, Globus pallidus interna as well is going to produce its GABA. The GABA is going to inhibit the thalamus, and the thalamus is going to produce less of the excitatory neurotransmitter to stimulate the motor cortex, and so there is the decreased motor movement. So what should we know? Just the first step, there is glutamate. The last step is also glutamate. But for the indirect pathway, the subthalamic that we have added also has glutamate. Hope that is fine. All right. So let's talk about something known as the. I don't know if it's a question. There's a mic that is open. Okay. So the break hypothesis is just what we have talked about on the inhibition part. So we know the general principle with which the basal ganglia functions. It acts like a brake. You are trying to prevent or suppress movements so that you don't produce movements that you don't want. You are controlling that. So to initiate the movement, excitation of the striatum is in one motor circuit is going to decrease the inhibition, and that's known as the releasing the brake. So the same thing that you have described. Remember, the striatum produces the GAPA, there is inhibition of what is happening in the indirect pathway. So just another thing, we have got different circuits in the same things that we've described. Those are the different circuits found in the basal ganglia. Now, when it comes to Parkinson's disease, there is one problem. The Remember the substantia nigra pars compacta was producing this dopamine that was stimulating the direct pathway and inhibiting the indirect pathway. So the neurons from the substantia nigra, remember how they were connecting, they were going to the striatum, and that's known as the nigrostriatal pathway because we're going from substantia nigra pars compacta to the striatum. So there is neurodegeneration of these neurons which produce dopamine. And so, because of this degeneration of the neurons, there are two problems. You are not producing dopamine to stimulate the direct pathway, and you're not producing dopamine to inhibit the indirect pathway. So, the overall thing is that there is a reduction in movement. If you can see this diagram, you can see the substantia nigra will produce the dopamine. Via D1, it is going to excite the striatum, and via D2, it is going to inhibit the striatum, and everything else happens. So it is proposed that there is an accumulation of a protein which is known as alpha synuclein, and this is the same protein that is going to be also seen in Lewy body dementia. That is why it is proposed that Parkinson's disease is also related to dementia, for forgetting with Parkinson's disease. So there are some pathways for dopamine that we need to understand. So dopamine in this system is in balance with acetylcholine. So in Parkinson's disease, dopamine is low. So acetylcholine is going to be high because these two guys are supposed to be in balance with each other. Meaning that for the treatment of Parkinson's disease, you are either looking for drugs that are going to reduce acetylcholine or look for drugs that are going to increase dopamine. In case the person can't take dopamine increasing drugs, they can take acetylcholine reducing drugs. So there is what is known as a reward pathway. Dopamine is manufactured in the cell bodies within the ventrotegmental area, and then it is going to be released to the nucleus accumbens and the prefrontal cortex. And then in the motor pathway, it is a substantia nigra that is going to manufacture the dopamine, and then is going to go to the striatum. So these are the two pathways for dopamine that are of a bit of importance here. Ventrotegmental to the nucleus accumbens and prefrontal cortex, and then from the substantia nigra to the striatum. Just so that we understand the pharmacological application, how we can treat this condition, we should be able to understand the breakdown, because I've seen the mastering part with pharmacology is a bit hard, but knowing is going to appear way, way simple. So dopamine, we can form dopamine from the amino acid tyrosine. So tyrosine can be converted to levodopa or L-dopa using the tyrosine hydroxylase, and then it can go to dopamine. Dopamine can be stored in vesicles. When an action potential has reached, it can be released by exocytosis. But can you see that when dopamine is attached to the nerves on the postsynaptic cell, it can be broken down by COMT. In the liver, dopamine can as well be broken down by COMT and MAO. And then you also have a channel through which dopamine can be reuptaken by the presynaptic nerve, that is its transporter. And then the dopamine can go and be broken down in the mitochondria by the monoamine oxidase MAO. So the reuptake is important to understand that for you to reduce the concentration of dopamine on the postsynaptic cell, you need these two enzymes, MAO and COMT. So if, because in this condition dopamine is low, you want to make sure that dopamine is high in this space, the synaptic cleft. And so the enzymes that are going to the drugs that are going to be able to inhibit MAO and COMT are going to be used in the treatment of Parkinson's disease. And of importance is that the D1 receptor and the D5, you have got five receptors for dopamine, D1 to D5. D1 and D5 are excitatory in nature. D2, D3, and D4 are inhibitory in nature. So this is a nice diagram summarizing the drugs that are going to be able to work in this system. You can see tyrosine can go to L-dopa, L-dopa to dopamine, and then dopamine can be released like that. The dopamine can as well be degraded by MAO. So the MAO, these monoamine oxidase enzymes, they can you can either have MAO A or MAO B. Now MAO A can deaminate or degrade serotonin, norepinephrine, and dopamine. These three monoamines. MAO B is selective to dopamine, not the others. So even most of the drugs you're going to see, they're going to be specific MAO B inhibitors. Okay. And then you also have COMT, which is located in the cytoplasm, which will be able to break down the dopamine to hormovanillic acid. So now of importance, you can see here the D2 receptor, those drugs that can antagonize D2. Like, yes, okay, the MAO A and MAO B are both breaking down monoamines. So the monoamines, we have got serotonin, 5-HT, norepinephrine, and dopamine. MAO A can break down all the three, but MAO B is going to be selective to break down only dopamine, to degrade it after it has already attached to the postsynaptic cell. So most of the drugs that we'll be able to use here will be the MAO-B, because they are specifically working on the dopamine. And why would we avoid the MAO-A inhibitors? Because they are inhibiting the degradation of serotonin and norepinephrine. So because they're working on many things, you expect also the increase of the serotonin and norepinephrine, and so that can contribute to the side effects. I don't know if that's okay. All right, thank you. So the MAO-B itself is the enzyme that is breaking down the dopamine. But the inhibitor for this enzyme that is breaking down the dopamine is going to increase the dopamine, so it will be high exciting. Then postsynaptic cell. Is that okay, Doc? All right, thank you. So the agonist for D2 agonist. Remember the D2 is we said the D2 is inhibitory in nature. So these guys can use them in Parkinson's disease just like here as we are going to understand. Now let's talk about first the features or the characteristics of or the signs and symptoms. You can find nice questions from papers on this. We can use the mnemonic trap. So for Parkinson's disease, we have got motor symptoms and the non-motor symptoms. So for the motor ones, we have got trap. T is for tremor, and this is specifically resting tremor. Someone is shaking when they are resting, not when they're doing something. Resting tremor, not intentional tremors, resting tremors. And then there is the rigidity. Rigidity is you have got a cogwheel rigidity where you have got small start and stop movements like a gear. You know the way robots move. You are moving slow like that, like a gear. That is a cogwheel, and that is a kind of rigidity that you are going to see in Parkinson disease. And then there's also the lead pipe rigidity, but the one you're going to see in Parkinson's disease is the cogwheel. And then the A is akinesia, which can also be bradykinesia, absence and involuntary and expected movements. Akinesia, no movement. So that can interfere with daily activities because you can't move. So you can't dress, you can't feed, you can't bath, and that can as well lead to facial muscle involvement. That's why we see someone has got a masked face or hypomimia, reduced facial expression. They can't control their face. More as though there is a problem to cranial nerve number 7, which is innervated and innervating the muscles of facial expression. And then the P there is going to be postural instability. So this one, together with the bradykinesia and the rigidity, is responsible for the typical gait because people with Parkinson's disease have got their own gait where someone is flexed forward, and we know that gait, right? So like this. So again, the symptoms, we have got motor symptoms, the tremors, the bradykinesia, the rigidity, postural instability. Those are the main ones. And then for the non-motor, someone is going to be depressed. They can't sleep. They can't smell, sweating, and also some GIT problems. So you can see problems can be psychiatric, those which are non-motor, depression, anxiety, hallucinations, delusions, dementia, cognitive impairment, compulsions, impulsive behavior. You can see it's really a lot, right? And then the autonomic nervous system basically behaving like anticholinergic, someone that has taken the anticholinergic drugs, those drugs against acetylcholine. Constipation, urinary agency, or incontinence, someone feels like just weeing, just a little time they want to wee, just a little time, or incontinence, finding it hard. Sexual dysfunction, orthostasis, when they just stand there is a drop in blood pressure, that is the orthostatic hypotension. And then on sleep there is a resting leg syndrome. They find it difficult to sleep because you are not feeling okay. You just want to be moving your legs every time. You just want to be moving your leg. You don't want to be, your legs can't be still. Sleep fragmentations. You sleep a bit, you wake up. You sleep a bit, you wake up. Insomnia. Remember, insomnia, the problem can either be you are failing to sleep, you are failing to initiate sleep, or you are failing to maintain the sleep. And also excessive daytime somnolence, where you are having someone is having, they are dozing in the day. And then for speech, there can be dysarthria, hypophonia, low voice, other features, fatigue, diplopia, weight loss, melanoma risk, olfactory impairment, and increased salivation. So you can see the problems are really a lot, right? What are the causes of Parkinson's disease? The age greater than 60 years is a predisposition factor, also genetics. The male gender is also one feature that is going to lead to a risk. So, in other words, if you want to be at a decreased risk, be a female. And environmental toxins like pesticides and heavy metals. Apart from that, there's also the drug induced Parkinson's disease, and I've seen quite a lot of questions on this one. What are some of the drugs that can cause or result into Parkinson's disease? The tricyclic antidepressants, the TCAs, okay, like amoxapine. This guy can cause, or discuss the antidepressants and bipolar disorders, which are the mood stabilizers, in tomorrow's discussion. I recorded the class, but I feel us discussing them and answering the questions will be way better than just recording the class. So that one I'll keep it. So this amoxapine, TCA, can induce Parkinson's disease. Antihypertensive drugs like the alpha methyldopa rezepine, the antiemetics, the drugs that we are using to prevent vomiting, droperidol, prochlorperazine, metoclopramide, and also antipsychotics. Now, can you see that these two conditions are actually basically opposites of each other? Because in psychosis, you can have high dopamine, but in Parkinson's disease, you have got low dopamine. Specifically, haloperidol. This guy is an antagonist for the dopamine. So this one can lead to the destruction of the dopaminergic nigrostriatal neurons. So there is the 1-methylphenine 1,2,3,6 tetrahydropyridine MPTP. So that is what is actually going to lead to this condition. Please take note of this, right? What do we desire to do when we are treating someone that has got Parkinson's disease? What is the goal? Number one is to provide control of signs and symptoms for as long as possible. You want to control the signs of and symptoms. Like you can barely cure the disease, just to control the signs of and symptoms. But then as you are doing that, you want to minimize the adverse effects. And the treatment is aimed at, remember, dopamine was low, acetylcholine was high. So the treatment is aimed at reducing the dopamine, reducing the acetylcholine, and increasing the dopamine. Okay. So here, the major treatment is going to be to increase dopamine. The minor is going to be to reduce the acetylcholine. On the treatment, in mild cases, you can simply give this MAO-B inhibitor, selegiline. You can also give amantadine and anticholinergics. The main treatment for Parkinson's disease is levodopa and carbidopa. And then you can also use other drugs to just help levodopa. Those are adjuncts. Any other medication, and there are a lot. You have got dopamine agonists. These guys are increasing dopamine, like bromocriptine, the MAO-B inhibitors like serotonin, rasagiline, and those guys which will enhance the release of dopamine. Amantadine is just a guy alone. And then you can also have the muscarinic receptor antagonists, benzotropine, and trihexyphenidyl. Okay. So, especially the anticholinergics, if someone can't take those drugs to increase the dopamine, you can give them the anticholinergics. And you can see how these drugs are working here, but to explain them stepwise. Okay, let's just describe them so that it will be way easier as we get to go forward. So this is the blood-brain barrier that is in this red color, and this is the central nervous system on top, and then below I've got the peripheral nervous system. So what you do is that the main treatment for Parkinson's disease is L-DOPA or levodopa. When you take levodopa can easily be broken down into either dopamine or into its other metabolite. So you are supposed to give other drugs to prevent a breakdown of this levodopa either to the dopamine, because remember, you don't want to convert the levodopa to dopamine while in the peripheral. What is the reason? In the peripheral, before reaching the central nervous system, this dopamine will easily be broken down by the marrow and the COMT. So you'd have done work equal to zero. So you want to make sure that the only way for you to convert the levodopa to dopamine is when the dopamine, the L-dopa, sorry, is in the central nervous system. So to prevent peripheral conversion of L-dopa to dopamine, you can give carbidopa. Why is carbidopa good? Carbidopa is good because this guy is not going into the central nervous system. So it will not prevent the conversion of L-dopa to dopamine in the central nervous system. It's only in the peripheral nervous system because it will not be able to cross this BBB. This guy inhibits the dopa decarboxylase, which breaks down the L-dopa to dopamine. And then you can as well give other drugs that will inhibit the conversion of L-dopa to its product. So drugs like entacapone and tocapone. But as you can see, the entacapone, of course, can work here. Okay, it's working in the peripheral nervous system. But the tocapone, just think of it, toto. It can work in the peripheral nervous system. It can as well work in the central nervous system by inhibiting the breakdown of dopamine to its metabolite. And then in the central nervous system, you have got your dopamine. So this dopamine can also be broken down by MAO-B to its products when you have already converted it. So the dopamine, you want to also inhibit it from being converted to its metabolites before it can work by the MAO-B inhibitors like selegiline and rasagiline. And then you can as well give other drugs which are dopamine receptor agonists like this bromocriptine, pegolide, pramipexole, and ropinirole. So this is a general how you are treating this condition and why you are giving which drug. Now here is the thing. This topic was taught by two people. Dr. Mwenda taught it and also Dr. Mwanza. But Dr. Mwanza is concentrating more on the physiology and little on the pharmacology. So when it comes to questions, there is a way Dr. Mwenda will bring her questions. I've seen her questions and I've seen her notes. But I've tried to integrate both from Dr. Mwenda and Dr. Mwanza so that for anyone that brings the questions, depending on which part they taught, will still be able to answer them well. So according to Dr. Mwenda, the initial treatment for Parkinson's disease, you want to give antimuscarinic drugs and also selegiline, which is a MAO-B inhibitor. And then for long treatment, long term, you give levodopa and the peripheral decarboxylase inhibitor, which is the carbidopa. And then according to Dr. Mwanza, you have got first line drugs, second line drugs, and the third line drugs. So the first line, you are going to use the dopamine agonists, and for him you need to know specifically which ones you are having for MCQ: bromocriptine, pramipexole, ropinirole. Okay, BPR right there. And then you have got the levodopa that you can give. But every time you're giving levodopa, don't forget to always give it with carbidopa. You can as well give the MAO-B inhibitor. So you still have your sertraline and your rasagiline. Not too different from here, just that here we had antimuscarinic as the initial treatment. So the second line then is going to be the antimuscarinics. Trihexyphenidyl and benzotropine. The third line, this is where you can give the amantadine, which is promoting the release, and the beta adrenergic antagonists. Now, this is in early treatment of Parkinson's disease. But then if Parkinson's disease was allowed and then it became maybe worse, later on, the first line treatment changes. So the first line treatment will now be these guys, and you are going to have the MAO-B inhibitors, you are going to have different drugs. This is after the condition was allowed to go on, like the bromocriptine, entacapone, pramipexole, sertraline, Second line will still remain the levodopa and carbidopa, but which was first line when it came to early treatment. Third line will be still the amantadine and apomorphine. And then later on, you can use the tocapone. But you know, this guy is just preventing the breakdown of your dopamine. So we can now look at each drug real quick and then we do answer the questions. When it comes to the anticholinergics, we have got these specific ones we'll use in Parkinson. Benzotropine, triexiphenidil, and then you can as well just get to look at these others. So these guys are working in the central nervous system, though these are centromuscarinic antagonists. You can see that they are central, meaning at least there's a reduction in those side effects in the peripheral. Though I don't think it can be just total in the central. So you are going to see on the side effects. The same side effects for anticholinergic drugs like constipation, failure to urinate, and those blurred vision. Okay. So these guys are recommended for treatment of Parkinson induced by dopamine antagonists. So if the drugs for dopamine that you are using are worsening the condition, don't use them. Instead, use those which are just going to reduce acetylcholine. These are actually dopamine antagonists, not agonists. So sometimes you have got Parkinson's disease that has been induced by drugs. Remember, you are giving dopamine antagonists. Let's say, for example, someone is psychotic. They have got high levels of dopamine. So you are going to be giving them the antagonist so that the dopamine doesn't work. But then that's a problem if someone is also psychotic. So in such a case where someone has got both psychosis and Parkinson's disease, you'd want to use the anticholinergics. So, what are the indications of the anticholinergics? They can improve the tremor and rigidity but have little effect on bradykinesia. This is important to take note. Tremor and rigidity but no effect on the bradykinesia. They can also provide benefit in drug-induced Parkinsonism due to antipsychotics. We've already explained how. They are also used during early stage of the disease, as we saw earlier, and they can as well be used as adjunct. So just a plus to levodopa. Selegiline, on the other hand, this guy can delay the progression of. Now, selegiline is MAO-B inhibitor. This guy is good. You can give it. It is going to delay the progression of PD, Parkinson's disease, and it can postpone the need to use levodopa. Meaning that, remember the initial treatment according to our good doctor, the antimuscarinics and selegiline. So when you give that selegiline, it will prolong it, at least prolong or postpone the time for you to use the levodopa. And well, that is going to be good because whatsoever levodopa's side effects are will not be coming because you're not using it. At least you've taken a bit of time. Okay. So these guys, the main ones that you use is benzotropine, triexiphenidil. So you can use it in patients with psychotic disease, but use it cautiously in the elderly. All antimuscarinic drugs should be used with cautious in the elderly. What are the adverse drug reactions? The same ones that we know for anticholinergic. Remember, anticholinergic is behaving like the cholinergic nervous system is rest and digest. So anticholinergic is behaving like the sympathetic nervous system. When you are running, you can't urinate. When you are running, you can't go to the toilet. And when you are running, what should happen to your pupil? It should become big. So the mydriasis, dry mouth, urinary retention, constipation. At high doses, confusion, delirium, hallucination. You can see Parkinson's like symptoms there. And then the contraindication, never use in prostatic hypertrophy. Remember, if the prostate is already big, it is compressing on the what on your urethra. You can't urinate. And if you give these drugs again, they are preventing urination. So it is worsening the condition. Don't use in glaucoma. Because in glaucoma itself, there is a this dilated pupil already. Okay. Dilated pupils in glaucoma is a problem because you know how glaucoma happens. There is that accumulation of the aqueous humor moving from the posterior chamber where it is produced going into the anterior chamber. So mydriasis itself is a problem, and mydriasis is one cause of glaucoma. But if someone has already glaucoma and then you are giving drugs that are causing mydriasis, that is worsening the condition. And then intestinal obstruction. Someone already can't go to the toilet, they have got intestinal obstruction, and then we give a drug that is causing constipation. So we are worsening just everything there. You have got drugs that to increase dopamine. So the one from talking about was just working on what? On acetylcholine. What are the drugs that increase dopamine? You have got those which will increase the central dopamine synthesis, the synthesis. That is going to be the levodopa, which is the precursor plus carbidopa. You have got those which will inhibit the dopamine breakdown. You have got COMT inhibitors and MAO-B inhibitors. MAO-B inhibitors, selegiline, rasagiline. And then the COMT inhibitors, they end in PON, tocapone, entacapone. But entacapone is only working peripherally. Remember total, is both peripheral and central. And then you have got dopamine receptor agonists. These guys are working like dopamine, bromocriptine, pramipexole. And then dopamine release, I have got only one guy, amantadine. Okay. And this is a nice diagram showing, I've tried to put everything on one slide here. You can see the carbidopa can inhibit the conversion of L-dopa to dopamine. And then you have got MAO-B inhibitors which end in gilin, selegiline, rasagiline. And then you have got the COMT inhibitors which end in capone, tocapone, entacapone. And then you have got the dopamine agonists. And these guys are a lot: bromocriptine, ropinirole, pramipexole, rotigotine, apomorphine, carbegoline, pegolide. At least just look at them so that you can be able to identify in MCQs, because I've seen some like that. And then you also have those which will release the dopamine, like amantadine. It's just one. So we've already discussed this really, but of importance when it comes to levodopa is this thing they call the wearing off effect or end of dose deterioration. What happens that when you give levodopa, sometimes there will be a point where it reduces the symptoms for Parkinson's disease and then it stops reducing them. So there is the what is known as the on-off phenomenon. Sudden loss of anti-Parkinson effect of levodopa which occurs irregularly and unpredictable. So the on is where you have got improved mobility. Someone starts moving okay and then off. They get back their kinesia, their hypermobility. That is because the levodopa has got a short half-life. So it's not taking much time for it to go off. And then the wearing off, the duration of the on state becomes shorter with each dose due to increased metabolism. If you give the dose, fine. Give another dose, the duration of action becomes shorter. Another dose shorter because of the breakdown. And this is solved by giving sustained release preparation or more frequent dosing. You continue to give more and more doses. Okay. So these are the problems associated with the levodopa. Another problem apart from wearing off and off, on and off, also dyskinesia and dystonia. Involuntary movements can occur in 40 to 90%. But remember, it's the problem. The problem in Parkinson's disease is the dyskinesia. And also the drug that you are giving is also getting to cause that problem. So this is what we are calling as the on or off phenomenon. Okay. So why is it good to give levodopa and carbidopa together? They will lower the effective levodopa dose, increase availability of L-dopa because you are preventing the breakdown of L-dopa or the conversion of L-dopa to dopamine in the peripheral nervous system, and that will reduce the side effects. This guy is given orally, it's transported actively into the central nervous system. Just contraindications: cardiac disease, okay, may still give slightly cardiac dysarrhythmias. So don't want to give in this condition. Active peptic ulcers, antipsychotic drugs should not be used in Parkinson associated with antipsychotic drug therapy. In other words, someone is psychotic, don't give them this drug. Remember again, how is it working? Some People that are psychotic, the dopamine is high. So you are trying to reduce the dopamine. But then you also have another drug that is trying to increase the dopamine. So that is a contraindication for someone with Parkinson's disease. And also someone that has got ankylosing glaucoma. Don't give cause of Medriatic. And also someone with melanoma. The L-dopa, besides it being a precursor for dopamine, it is also a precursor for melanin. So it can activate, if someone has got this melanoma, it can activate the malignant melanoma, and that can worsen the condition. When you are giving this drug, don't give it with someone as you are taking high protein meals, because they'll be able to compete on the uptake. And then when it comes to vitamin B6, pyridoxine, it will be able to reduce the effect of L-dopa due to increase the peripheral metabolism, because this vitamin B6 will actually be breaking down the L-dopa, so it will reduce its effect. And then for the, you also have non-selective MAO inhibitors. We'll talk about this guy when we talk about the antidepressants in the tomorrow's class. So when you give this guy levodopa with phenylzine, phenylzine is an example of hydrazines, which, because when you're classifying the antidepressants, the MAO, non-selective MAO inhibitors as antidepressants, you can classify them as hydrazines and non-hydrazines. The hydrazines, that's where you find the phenylhydrazines and hydrocarbazine. And he said, make sure that you know, I think I asked the question, what is the mechanism of action of hydrocarbazine? It is also a MAO inhibitor, non-selective, used in antidepressant. So this guy, when you use it with levodopa, it can reach to hypertensive crisis. Why is it so? Remember, levodopa is trying to increase the monoamine, specifically dopamine. Non-selective MAO inhibitors, they are preventing all the enzymes that break down monoamines, meaning that the monoamines are going to be high, and that leads to hypertensive crisis. And this is one problem also in antidepressants that we are going to see. There's what is known as the serotonin syndrome or the hypertensive crisis because of the drugs. So you want to make sure that you take note of this. And also these guys you are going to see also in antidepressants. You don't give them with foods that have got tyramine like cheese. They'll show the cheesy effect. Things like uh, wine, the red wine, also soya chunks. You don't want to give those because they have got tyramine and they will lead to the cheesy effect. So you don't give them together. Side effects, something we can know there. Dopamine receptor agonist. I think we've talked about enough about this. We've basically mentioned everything. The side effects are really a lot. Apomorphine. This is an agonist of dopamine. Clinical use is for the temporary relief of off periods of akinesia in patients. Amantadine, this guy is a releaser of dopamine. What's the mechanism of action? It can increase dopamine release, decrease the reuptake of dopamine, act as an antagonist at muscarinic receptors, meaning that it's preventing them, the acetylcholine, and also antagonist at NMDA receptors, which are for glutamate. So it's a good guy. Okay. So use it with caution in patients that have got seizures and heart failure. The only bad things, the adverse effects of amantadine, this release of, is you can see this appearance of this person here. Livido reticularis, the skin changes, and then there's also angioedema. These are problems because it damages epithelial cells. And remember, it is one of its mechanism of action is NMDA antagonism, like antagonizing the glutamate. So it can lead to restlessness and hallucinations. That is again one problem. Dry mouth because it was also anticholinergic. And then also insomnia, confusion, hallucination because of the dopamine like side effects. Take note that entacapone, which is COMT, has no hepatotoxicity. The tocapone is going to be a problem for that condition. So when you combine levodopa plus carbidopa, and then you add also entacapone, which is preventing the breakdown of this dopamine, that to form what is known as Talevo, the combination of levodopa, carbidopa, and the entacapone, Stalevo. The problem with these guys, the COMT inhibitors, is urine is going to be orange. Tocapone itself can lead to acute hepatic failure, but entacapone can't do that. And also dyskinesias, selegiline and rasagiline. These guys are metabolized by 2-dismethylselegiline, which is anti-apoptotic. So you can now guess the side effect, preventing apoptosis. But rasagiline itself, it can be used in preventing the MPTP induced Parkinsonism. Remember, this was one cause of Parkinsonism. So rasagiline is the one that can be used for that. And then just some contraindications for these COMT inhibitors. Don't use with TCS, tricyclic antidepressants, selective serotonin uptake inhibitors, and also restricted with the tyramine. Okay, don't use them with tyramine. These are actually not the COMT inhibitors, but MAO inhibitors. It's the MAO inhibitors that you can't do this because those guys are also used in antidepression. Please take note of this. Selective serotonin uptake inhibitors, drugs usually provide good control of motor signs. After 4 to 6 years, whatsoever that you do will not work. So these drugs that you are using here will only work up to this long. Additionally, they can cause disability of late disease, can lead to postural instability and dementia. So let's just take note of that. These ones, I just said some multiple choice questions which are being read. Which of the following conditions is due to reduced activity of the subthalamic nucleus, hemibalismus? Which of the following conditions is associated with damage to the striatum, athetosis? Just take note of that. Okay, let's go now to questions. Number one, which of the following drugs used in the management of Parkinson's are most likely to induce drug interaction? Levodopa, apomorphine, selegiline, amantadine. Which one would we go for? So these ones now we'll be discussing since we've discussed the entire topic. So these ones we can be discussing together. Which of the following drugs is which of the following drugs used in the management of Parkinson's disease are most likely to induce drug interaction? A. Levodopa. B. Apomorphine. C. Selegiline. D. Amantadine. Anyone? Let's discuss so that it will be way easier if we discuss and do not forget. Suggestions can be dropping in. Okay, should I suggest an answer and then someone explains why they think I've chosen that one? C. Selegiline. Anyone with an idea why for me I've gone with that one? Remember, we are from mentioning that selegiline is a MAO B inhibitor. And for these guys, you can't use them with TCAs, you can't use them with selective serotonin reuptake inhibitors, can't use them with the tyramine. You can see the limitation with the drugs. Hope that's okay. Yes. Yeah. Oh, great. So there's another reason that has been suggested, another just to make sure that we don't use it because of a lot of drug interactions. Thank you so much. Let's answer this one. Long-term levodopa use may lead to all of the following except wearing off-on phenomenon increase in and Parkinsonian effect of levodopa, dyskinase and dystonia stop the progression of the disease. Which one would you pick for this one? Yeah, thank you so much. All the answers that have been suggested, I agree also with them. There's no drug that will stop the progression of Parkinson. Parkinsonism is associated with the following except tremors and rigidity, hypokinesia, ataxia, unstable gait, numbness in the extremities. Which one can we pick for this one? Which one of these is not a feature of Parkinsonism? Anyone? Numbness E. Is there a different suggestion before we can move to the next? Yeah, because we have seen, we know the gate for Parkinsonism. Someone, the walk is disturbed. So obviously that can lead to ataxia. For the others, we know they are part of the trap. The pathophysiologic basis for anti-Parkinsonism therapy is selective loss of dopaminergic neurons, the loss of cholinergic neurons, the loss of glutaminergic neurons, increased GABA activity. Which one would we pick for this one? A, all right. Is there another one besides A? Or we all agree with A? B, loss of cholinergic neurons? No, right? Okay, so A, we agree. So the dopamine, if we lose those dopaminergic neurons, just the low dopamine is going to make acetylcholine to rise. It's more like you want to have a certain concentration of all these neurotransmitters. So if one falls, another one has to rise. Which of the following is a dopamine receptor agonist? Metoclopramide, bromocriptine, fluphenazine. This one, it was A. All right. So which one is a dopamine receptor agonist? Metoclopramide, bromocriptine, fluphenazine, diconate, amantadine. There's one suggestion for B. Anything different from anyone? Yeah, so it's B. That's correct. Which of the following drugs used in the management of Parkinson's should be used with care in patients with a history of seizure and heart failure? Acetylcholine blocking drugs, amantadine, apomorphine, entacapone. Anyone for this one? Any suggestion? I think it's direct from something that I showed. Where is Yeah, so here, caution in heart failure. So that's amantadine. All of the following statements concerning the pharmacological attempts in the management of Parkinson's disease are correct except restore dopaminergic activity, alleviate many of the motor features of the disorder, restore the normal balance of cholinergic and dopaminergic influence on the basal ganglia. So which one is false? What is a pharmacological attempt in managing Parkinson's disease? Is to restore dopaminergic activity or to elevate many of the motor features or to restore the normal balance of the two neurotransmitters. Which one, Doc? Oh, D, B? Okay, thank you. Is there anyone with a different one or we all agree? Okay. So I don't know what I'm hearing. I'm hearing D, but do we have D here? So this one is one option, isn't it? Restore the normal balance of cholinergic and dopaminergic influences on the basal ganglia. Oh, B. Yes. Yes. So alleviate many of the motor features of the disorder. Really not. You don't want to worsen the condition. This one, this one, it was amantadine. Okay. All of the following statements about the dopamine receptor agonist is correct except have lower incidence of the response fluctuation and dyskinesias unlike levodopa therapy may be used for treatment of patients with Parkinson's who are taking levodopa and have end of akinesia, treatment of patients with Parkinsonism who are becoming resistant with levodopa has more adverse effects. Now, let me just mention something about these agonists because I rushed not to mention them. Yeah, so these agonists, we classify them into ergot derivatives and the non-ergot. Ergot, these are the old ones, bromocriptine, pegolide, and then the non-ergot, these are prempexo and the ropiniro. You can see also where they are working. These are working on D2, this one D2 and D1, Prampex on D3, Rampex on D2. Monotherapy, these guys are going to be less effective than levodopa unless you combine them, use them as adjuvants. And in advanced stages, these guys are used as adjuvants. These guys may delay the need to use levodopa, just like sertraline and rasagiline do, specifically sertraline, which delays the use of levodopa. They have got a lower incidence of the responsive fluctuation and dyskinesia, unlike levodopa therapy. They can as well restore BAD for patients who have never responded. They can help for those patients who have never responded to levodopa for these antagonists. And you can use them for in patients taking levodopa, those patients who are on end of dose akinesia or on off phenomenon, and those patients who are becoming resistant to levodopa. So those are all functions. But take note of this one, that bromocriptine is used for the treatment of Parkinson and also hyperprolactinemia or galactorrhea, which is high prolactin. When you have got high prolactin, what happens is that there's going to be less estrogen to be produced. And so any drug that increases the high prolactin leads to infertility, because less estrogen is going to induce infertility. Okay. So it can be used for treatment of infertility in women because it's fighting against the high prolactin. While the prampezo is a free radical scavenger, meaning that it can help in getting to attach to these free radicals and so helping in those conditions. The side effects are generally the same with levodopa. So now we can answer. All of the following statements about the dopamine receptor agonists are correct except have lower incidence of the response fluctuations, and dyskinesia, unlike levodopa, may be used for treatment of patients with Parkinson who are taking levodopa and the end of akinesia, end of dose akinesia. Treatment of patients with Parkinsonism who are becoming resistant has more adverse effects than levodopa. Which one can we pick? D. One suggestion D. Any other suggestion from anyone? All right. I also agree with D. So the rest of those we've just mentioned. Which of the following drugs is best to use for early symptomatic management of 1-methyl 4-phenyl 1,2,3,6 tetrahydropyridine MPTP induced Parkinsonism? Rasagiline, catechol methyltransferase inhibitors or the COMT inhibitors, acetylcholine blocking drugs, apomorphine. Anyone? Any suggestion? This one we read it just direct, isn't it? Yes, doc. Yes, I'll share it. All, all right. So I want us to look at rasagiline. That's the only thing I showed that had that effect. Okay, this one here. Rasagiline. Prevention or preventing the MPTP induced Parkinsonism. Hope we've seen that. So where is that question? So what would be the answer here then? Y- Yes, A. Which of the following statements is correct concerning the best drug used for long-term management of Parkinsonism? Levodopa and peripheral decarboxylase inhibitor, antimuscarinic drug only, dopamine agonist only, monoamine oxidase inhibitor, and antimuscarinic drugs. Anyone with this one? Thank you so much. So that's a right according to Dr. Mwenda's notes. The first one is going to be the antimuscarinic and the rasagirin. And then the what you use later on is levodopa and the carbidopa. All of the following are the goals of therapy in Parkinson's disease except increase dopaminergic activity, reduce cholinergic activity, provide control of signs and symptoms for as long as possible, cure the disease. It's D. Thank you so much. Which of the following drugs may induce Parkinsonism? Dopamine receptor antagonists, monoamine oxidase inhibitors, catechol methyltransferase inhibitors, amantadine. If you can see B, C, and D, these guys are used for treatment, isn't it? But then an antagonist is trying to reduce the dopamine, which is already low in Parkinson's disease. So, which one can we pick? It's A. Thank you so much. Idiopathic Parkinsonism develops when there is reduction in which neurotransmitter glutamate, serotonin, GABA, dopamine. It's D. Thank you. Which of the following can be prescribed with a drug of choice to decrease dyskinesia? Benzotropine, trihexyphenidyl, tocapone, bromocriptine. Any suggestion? Remember we had mentioned something to say for rigidity and the akinesia. We could use those drugs that are going to work against acetylcholine. So those are acetylcholine antagonists. So which one can we pick here? Now, specifically the acetylcholine guys, we have got benzotropine and trihexyphenidyl. But then there is a statement which I just read direct. There are two things on the features for Parkinsonism that you are preventing using anticholinergics. I think it's the dyskinesia that we left out to say it can't be treated by the anticholinergics. So you need another drug, if we remember. The tremors and rigidity can be treated using the anticholinergics. A and B would have been the answer, but dyskinesia will not be treated using anticholinergics. So that one you can use bromocriptine. Which of the following can be used with antipsychotics? Levodopa, carbidopa, entacapone, benzotropine, or benztropine. Remember, we said that for antipsychotics, you can't use any drug that will be increasing dopamine because anything that increases dopamine is against the psychosis because psychosis you are trying to reduce dopamine. So, in other words, which one of these drugs is an antimuscarinic drug? Yes, it's D. Which of the following can cause hypertensive crisis in high doses? Remember, and hypertensive crisis, also known as a serotonin syndrome, can be caused by MAO-B inhibitors. So, which one is a MAO-B inhibitor? Matadine, bromocriptine, selegiline, pegolide. C. Thank you so much. Yes. Which of the following is a peripheral side effect of levodopa? Anorexia, delusion, insomnia, erectile dysfunction. So erectile dysfunction, I don't think it is a side effect of levodopa, but delusions, insomnia, those are side effects. But the only thing is that they are peripheral. But for anorexia, someone stops eating because they're afraid of gaining. That's a side effect for levodopa. A patient with advanced Parkinson's was prescribed an adjuvant to his therapy. He later developed livedo reticularis. Which of the following was he prescribed? Pergolide, amantadine, pramipexole, bromocriptine. There is only one drug that can cause livedo reticularis here, and that drug is a dopamine releaser. Which one can we pick? B. Thank you so much. Amantadine. A patient with glaucoma developed Parkinson's. Which drug should not be prescribed? Levodopa, entacapone, pergolide, pramipexole. In other words, which drug was causing mydriasis and so it was contraindicated in glaucoma? It's the same drug of choice for Parkinson's disease, which causes glaucoma. Which one? Yes, it's levodopa. Which is the most efficacious drug in treatment of Parkinson's? Selegiline, benzotropine, levodopa, pramipexole. The most efficacious. Remember, the most efficacious is the same levodopa. And then we have got these beautiful questions. This beautiful question, then we are done. It was from 2018 exam. A 68-year-old right-handed man was referred for neurologic evaluation of tremor. The patient had first noted tremor of the right hand when driving and holding a newspaper approximately 2 years previously. Initially, tremor seemed to be intermittent but gradually progressed to be present continuously throughout the day. Two glasses of wine in the evening could reduce but not stop his tremor in his non dominant hand. He also had chronic right shoulder pain for 6 months, duration for which his primary physician ordered a shoulder x-ray which was read as normal. Despite these symptoms, he did not feel that he was functionally impaired in any way. Upon further questioning, he reported mild difficulty getting up from the low chair in his house and had both chronic constipation and erectile dysfunction for at least 5 years. He denied noticing any change in his sense of smell, but his wife stated that he often commented that her cooking was less flavorful. His wife had begun to sleep in the guest room due to the patient hitting her in his sleep. His neurologic examination was remarkable for a poker face and soft voice, a delay in right shoulder shrunk, and mild cogwheel rigidity in the right arm that was only noticeable with voluntary movement of the opposite hand. His posture was slightly stooped and he walked with decreased right swing and a more pronounced pronation or supination tremor in the right arm. What is the most likely diagnosis of this patient? Elucidate all the possible symptoms this patient is presenting with to support your diagnosis. Let's start with the diagnosis. What do we think is the diagnosis here? Parkinson's PD. Thank you so much. And then let's mention what are the possible symptoms in this scenario that can relate to Parkinson's disease. Yeah, the mild cogwheel rigidity number one. So we are remaining with about eight. Even tremors, yes, number two. Anything else that you've noticed? I've noticed poker face if we can see. Number three. Anything else? Difficulty in movements. Maybe the akinesia or dyskinesia. Number four. And then anything else? Yes, his posture was slightly stooped and he walked with a decreased right swing and a more pronounced pronation. So the stooped posture, yes. Anything else? Difficult getting up from the low chair. No, just as many things as you can see, just mention them. Let's go to B. Briefly describe the pathophysiology of this disorder with reference to normal basal ganglia function. 10 marks. So for questions like this, it's important to understand which component they've brought it. If they brought it on the physiology part or on the anatomy part or on the pharmacology part, because if it comes on the physiology part, I feel it is important to talk about the direct pathway and the indirect pathway and how they are going to be affected. If we are to describe the pathophysiology, other than just saying there's a reduction in dopamine, you end there and there's an increase in acetylcholine. So, what would be the importance of the same dopamine if it is there or if it is not there? And then suggest treatment for this disorder, highlighting the mechanism of action of the drug. So, I tried to suggest some things which I saw. Most likely diagnosis Parkinson's, their motor symptoms and non-motor symptoms, all these like reduced sense of smell, hyposmia, soft voice, hypophonia, poker face, reduced facial expression, hitting his wife in the sleep disturbance, erectile dysfunction for the past 5 years, constipation, chronic constipation for at least 5 years. And then pathophysiology, this disease is neurodegenerative, affecting the basal ganglia. And the problem is there is a loss of the dopaminergic neurons in the substantia nigra pars compacta by an unclear mechanism which are thought to be through a protein which is known as alpha-synuclein, which is believed to accumulate and then cause a damage leading to the dopamine deficiency in the striatum. Remember, when the dopamine comes from the substantia nigra pars compacta, it goes to the striatum. So there's going to be less stimulation of the direct pathway and less inhibition of the indirect pathway. The net product is going to be reduced movement, and the decrease in dopamine will cause an increase in acetylcholine. This imbalance is what is going to lead to the different characteristics of Parkinson's disease, like the tremors, the bradykinesia, the rigidity, the postural instability. For the treatment options, you can use drugs that increase dopamine activity. For example, you have got those drugs which increase dopamine synthesis, like levodopa and carbidopa, which is the precursor. Those which inhibit dopamine metabolism, COMT inhibitors like tocapone and entacapone, MAO-B inhibitors like selegiline and rasagiline, dopamine receptor agonist bromocriptine, pramipexole, pegoride, dopamine releaser amantadine. You can also have those which work on acetylcholine, benzotropine, trihexyphenidyl. These are the main ones. So that was it for today's neuroscience, and this is where we're going to end.